Hello, everyone. Good evening. I hope everybody can hear me and see me okay. Delighted to welcome you to this evening's webinar, which is the final installment in our GP webinar series for 2024. So this is the fourth webinar that we're doing this year. Traditionally, we try and do 6 a year, but due to unforeseen circumstances, it'll be just the 4 for this year, but we're hoping to have 2 in January. So we'll be back again after this one very soon. So just to give you a little bit of background about tonight's webinar, so we'll be joined by Dr. Gary Cooney this evening. Dr. Cooney is a consultant psychiatrist here in eating disorders with our team at St. Patrick's Mental Health Services. And over the course of the hour's webinar, Dr. Cooney will present a clinical overview of binge eating disorder, its features, its diagnostic criteria, and as well, there'll be some discussion around the evidence base for effective treatments, or evidence-based effective treatments. Dr. Cooney will also be discussing advice on clinical screening and referral pathways to treatments. For any GP attending live this evening, ICGP CPD certificates, it's always a mouthful, are available. So we'll aim to hopefully send those to GPs within the next 4 weeks. There'll also be an opportunity at the end of Gary's presentation for a short Q&A. So if you do have any questions, please feel free to submit them throughout the webinar using the Q&A function that you'll see at the bottom of your screens, and we will try and get through as many of those as we can. So I think that's enough for me. We'll get started and I'll introduce you to tonight's speaker, who, as I've mentioned, is Dr. Gary Cooney. You're very welcome, Dr. Cooney. Thank you so much for joining us this evening.
Hi, good evening, everybody. Thanks very much, Sinead, for that introduction. It's great to be here. So I'll just begin by sharing my slides with everybody. Give me one moment. Yes, so indeed, thank you very much, everybody, for joining this evening. I'm delighted to be here to discuss with you all binge eating disorder, a topic that perhaps doesn't get the limelight that it perhaps deserves. Binge eating disorder is the most common of all eating disorders. It's a major public health concern. And yet it tends to get overlooked by ourselves and as practitioners, I think, by the media, by patients themselves. When we think of eating disorders, it's very often anorexia nervosa or bulimia nervosa we think about. And perhaps as they're the first that come to mind. But indeed, when we think of it on a population level, it may be that binge eating disorder is the one that's perhaps doing the most damage. So a hope I have, I suppose, coming into this evening is that binge eating disorder will take a more central stage in our thinking around eating disorders, and that we can move towards quicker recognition, quicker diagnosis, and being able to access treatment for individuals suffering, and very often suffering in silence with this condition, and get them into the treatment that they need. So just to begin, I suppose, this evening with an outline of what we're going to be discussing, I thought we'd begin with some definitions of binge eating disorder, and having a think about the various diagnostic criteria that are in play between the ICD-11 codes and the DSM-5 codes as well. We'll take some time to have a look at some of the psychiatric comorbidity associated with binge eating disorder, and indeed some of the physical health problems that arise with the condition as well. We'll take some time as well to think about the origins of the disorder itself, before looking at some of the epidemiological features, and then turn our attention to some of the competing etiological models about the origins of the illness. We'll turn then to treatments that are available for binge eating, and various interventions that have efficacy. Before looking, I suppose, from a primary care perspective, particularly thinking about screening, issues around the treatment gap and how we might overcome that in binge eating disorder, and then taking an overarching primary care approach to binge eating disorder management. And if I may, I'd like to conclude just with a couple of slides to talk a little bit about what we're doing here in St. Patrick's Eating Disorders Programme, in terms of developing some of the binge eating disorder services in the weeks and months ahead. I should say that the references to all the research I'm quoting are at the end of the slides, but they're also embedded in the notes of the slides. So, and I'm happy to share the notes, share the slides after the talk. So for the details on the references, you'll be able to get those through sharing of the slides at the end. So what do we mean by binge eating disorder? Well, one unifying definition that all of the criteria, diagnostic criteria, seem to rally around is this idea of recurrent, brief, psychologically distressing binge eating episodes during which patients lack a sense of control and consume larger amounts of food than most people would under similar circumstances. And I've highlighted a few important points there. Distressing, these are associated with intense emotion, intense distress, and that'll come up through the course of our talk today. And a subjective sense of loss of control. Brief, these episodes tend to occur within something like a 2-hour framework or less than 2-hour framework, time frame. So it's not the same as people eating large amounts steadily throughout the days. These are often the case of people trying to resist the binge over a long period, and then that resistance being broken down and having a short and discrete episode of loss of control over eating. As I say, the most common of all eating disorders, affecting a lifetime prevalence of around 2 to 3% of adults. And it's recurrent in terms of we'd expect this to be at least once a week, 1 day a week for a period of 3 months. So taking a little bit more of a granular look then at the diagnostic criteria, and I find the DSM-5 criteria really helpful to just get a better sense of what's going on for individuals with this condition. Criterion 1 we've already sort of touched on in the last definition, but if I could draw your attention to criteria 2, the subsections there: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food even when not physically hungry, eating alone because of feelings of embarrassment about how much one is eating, and feeling disgusted with oneself, depressed or very guilty after overeating. And you'd expect to see 3 or more of those criteria being met. For DSM-5, all of the criteria that you see listed in front of you would need to be met. And as I say, within criteria 2, you'd expect 3 or more. So I think that sort of spells out in a bit more detail the experience of somebody having a binge eating disorder episode. The other criterion to draw your attention to is number 5 there. Binge eating is not associated with regular use of inappropriate compensatory behavior. So you don't get purging, fasting, excessive exercise, use of laxatives and so on that you might get in other eating disorders, particularly bulimia and nervosa. So that tends to be a distinguishing feature between the two conditions. And then the DSM highlights a severity grading, as you can see there below, in reference to how many binge eating episodes an individual would have per week. Turning then to the ICD-11 characteristics of binge eating disorder, and you can see fairly similar. Again, I've highlighted there or put in bold there some of the features that have cropped up before. That again, that distressing element, subjective loss of control, distinct period of time, and no compensatory mechanisms. The one difference, I suppose, with ICD-11 is that there is significant impairment specified. We're looking for significant impairment that binge eating disorder has on an individual in their personal life, family, social, educational, occupational domains, that kind of thing. So what is a binge? I think one of the difficulties with this disorder is that we use the term binge fairly freely in our everyday life. We talk about binging on Netflix, binging alcohol binges, shopping binges, as you can see with the definitions there in front of us. And that experience is very, very different from the binge experience within a binge eating disorder. It's quite usual for people to eat in excess or drink in excess and, you know, with maybe a little bit of regret, but very swiftly move on from it. There's nothing unusual. We'd all do that from time to time. However, this definition of binge doesn't capture what the experience of somebody with a binge eating disorder has in terms of that subjective loss of control, and secondly, that frequency of binge experience. Often thinking about the aftermath of a binge, for people who binge on a very infrequent and sort of general normal kind of basis, you would expect people in that circumstance to move on from it fairly quickly. If they might eat a little bit less the next day, they might go for a run or something like that, to a small amount of compensation might be built in, but that would be it. Whereas for binge eating disorder, once a binge takes place, there's an initial immediate relief from the psychological and the physiological buildup, the sense of trying to resist the binge for a long period. So there's this immediate positive experience, followed very quickly by shame, disgust, guilt, hopelessness, and other difficult feelings as well. So I think part of our difficulty and why I'm highlighting this is because I think when we talk about binge eating disorders, it's difficult for patients and maybe even for practitioners to be very clear on that distinction when we capture them both by the term binge. What is considered unhealthy, disordered behavior, and what we might expect in the general population? How do we distinguish between those in our thinking for our patients, and how do they communicate that to us in a way that makes sense? Thinking about some of the clinical features then and associations of binge eating disorder, increasingly there's evidence that this is not just a disorder of adulthood, but can occur in adolescence as well and in childhood. Indeed, the average onset ranges from late teens to early 20s, and there's a mean persistence of about 4.3 years. And what we find is that it tends to run a sort of a phasic course, with people maybe experiencing binge eating for a discrete period of time, maybe several months to several years, and then it may go quiescent, and they may have a period where there is none of this behavior, none of this disordered eating at all, only to then relapse at a different point in their lives. That's a kind of a classic or typical picture that you would get with untreated binge eating disorder. Earlier onset tends to be more associated with worse outcomes, perhaps requiring more complex intervention. And in common with other eating disorders, those suffering from binge eating disorder have real difficulties in describing emotions. And I think that's key when we talk in a few moments about some of the origins of this disorder. Very difficult identifying what emotions the individual is going through, lower emotional regulation, and lower mindfulness scoring as well. So real difficulties understanding, knowing, describing, explaining their emotions, and modulating them as well. Binge eating disorder is also associated with high rates of interpersonal problems as well, and those indeed can relate to those complexity of emotional experience as well. And there's definitely a perceived quality of life and health significantly lower in BED versus non-BED populations. Common to many eating disorders, there is a clinical overvaluation of shape and weight in up to 60% of binge eating disorder patients. The real focus around body image, around weight, shape concerns, which perpetuates the binge eating practice, as we'll discuss in a few moments. 50% of those with binge eating disorder have a BMI within the obese or overweight range, and I think which says to us as well that 50% of patients with BED, perhaps a more surprising find, have a normal BMI or a BMI within what's described as the normal range. So eating disorders can occur at any weight or any shape, and that's brought home by that evidence there around binge eating disorder, as again associated with poor impulse control, poor emotional regulation, and indeed it's often difficulties around emotional regulation that precede a specific binge eating episode. There's a very high degree of psychiatric comorbidity with this disorder as well. In fact, up to 80% of those with BED would have a lifetime prevalence of at least one other psychiatric disorder, with 50% having up to 3 other psychiatric disorders. Suicide attempts are 23% of those with BED will experience a lifetime episode of a suicide attempt, which is between 4 and 5 times greater than healthy populations. So just to focusing our thoughts into the seriousness of the disorder in terms of the risk associated, risk of self-harm, risk of suicide as well. This slide just gives a bit more detail on that concern around the complexity of the psychiatric comorbidity. You can see unipolar depression, anxiety disorder feature very heavily, alcohol use disorder, PTSD, and then a range of personality disorders as well are associated with binge eating disorder, borderline personality disorder, avoidant and obsessive compulsive PD as well being the ones that feature most prominently. And of course, there's much thought given to some of the physical health complications of binge eating disorder as well. Standardized mortality associated with binge eating disorders between 1.5 to 1.77. So really pointing to the seriousness of having the condition in terms of associated morbidity and mortality. And common conditions occurring with binge eating, as you can see listed there, vasculopathy type conditions, heart conditions, elevated cholesterol, diabetes, the metabolic kind of picture as well as you might imagine. Very common as well, binge eating disorder in candidates for gastric banding as well. Sometimes it's a contraindication for proceeding to obesity surgery, but it depends on the center. Certainly internationally, there's a bit of variety around that. You can see the mean BMI for individuals with BED in a certain US sample with 33, almost 34. And up to 20% of individuals, studies have shown, with type 2 diabetes have an underlying eating disorder, which is very often binge eating. There's a strong association as well with non-alcoholic fatty liver disease, and it's associated with multiple cancers as well, including those that I've listed there: colorectal, renal, breast, ovarian, prostate cancer, all overrepresented in the binge eating population. I suppose it's worth reflecting, one of the challenges in identifying binge eating disorder is that these sort of patients may be coming to you as their GP with physical health concerns. There may be a focus on the statins or the glycemic control or whatever it is, or the antihypertensives, and a lot of the focus in a time-limited patient-doctor interaction may be focused on the physical, and it doesn't lend itself the time perhaps to consider what psychological origins are perhaps perpetuating the problem and are underlying a lot of the physical concerns that are being presented. So we'll take a look now, moving on in our presentation, to have a think about the origins, epidemiology, and some of the etiological models for the disorder as well. So binge eating was first described back in 1959. A University of Pennsylvania professor, Albert Stunker, noted a proportion of individuals with obesity had significant problems with binge eating. But unfortunately, that observation remained just an observation for several decades. And it wasn't really until the 1980s that further studies around this binge eating pattern in the context of obesity emerged. And studies at that time showed up to 25% of those seeking treatment for obesity were experiencing binge eating and did not qualify for the diagnosis at the time of bulimia nervosa. By the mid-1990s, the American Psychiatric Association had highlighted this clinical collection, this clinical syndrome, as worthy of further investigation, study, and delineation. But it wasn't until 2013, a little over 10 years ago, that that binge eating disorder was incorporated into the DSM-5 as its own standalone bona fide eating disorder diagnosis. So you can see why perhaps it is a little bit behind when compared to other eating disorders, because it's relatively new, and therefore perhaps hasn't been talked about, taught. Maybe there's not been as much research as you would expect compared to other eating disorders, perhaps related to it being relatively new to have that kind of legitimacy by being incorporated into the diagnostic manuals. There is an important note in all eating disorders around this concept of diagnostic drift. As practitioners, we do focus very much on individual diagnoses, but sometimes that can be quite meaningless to an individual patient who at different points of the lifespan may drift from one eating disorder into another. And that's something we would see fairly frequently in our work, that somebody presenting with, say, a bulimic picture may return with a very severe anorectic picture several months or years later, suggesting the underlying common pathologies. And in binge eating disorder, there's a suggestion that up to 16% transition from binge eating disorder to another eating disorder, most commonly bulimia nervosa, within 1 year. We've mentioned prevalence before, and we can see it's slightly higher in women, and it's also at higher rates in those with higher BMI. So a 10-fold increased risk of having binge eating disorder in those with a BMI higher than 40 compared to those within the range of 30 to 35. But again, as I mentioned before, this can occur at any BMI whatsoever. Thinking about the genetics, there's heritability rates, heritability accounts for 39 to 45% of the phenotypic variation, suggesting a strong underlying genetic component. And there's also studies demonstrating the association between childhood maltreatment and those who've experienced childhood abuse compared to healthy controls would be 2 to 4 times more likely to develop a binge eating disorder. So we'll take a moment to think about what triggers a binge. And I suppose there's a distinction I wanted to draw between maybe what causes binge eating disorder, what the etiological origins of the disorder are per se, and then secondarily, what might cause a binge on a specific day? What are the proximal causes that make somebody or that lead somebody to carrying out a binge at a specific moment in time? And Christopher Fairbairn, who's leading researcher in eating disorders going back since the 1980s, would point to quite a helpful pathogenic model around binge eating disorder, which points to low self-esteem ultimately relating to body image, generating a lot of anxiety and a lot of negative emotions. And this in turn leads to a dietary restriction pattern, which carries on for a period but soon becomes overwhelmed, and in turn can trigger a binge. And that's the same cycle you see in bulimia nervosa, except there's this compensatory mechanism that comes in, which is often absent in binge eating disorder. So we can think, in looking around that slide there, of the various different emotional distresses. There's mention there of undereating, dietary lapse, feeling fat, gaining weight. All of these things relating to this concept of I'm not comfortable in my skin, I'm not happy with my body, I have low self-esteem, the low self-esteem playing out in terms of how one physically appears or feels about their body, leading to these overwhelming emotions that drive a dietary restrictive pattern, which can after a point become physiologically or psychologically overwhelming, leading to a binge disorder. But of course, all of this, it's worth saying and worth spending a slide or two on the fact that all of this occurs in a difficult socio-cultural climate. I didn't need to look particularly far to find evidence of that last weekend, preparing my slides for the talk tonight. Last weekend's Daily Mail online, speaking of Kathy Bates, one of my favorite American actors, who had lost 100 pounds, and she was on the red carpet there, and whatever excellence in career that she's achieved was of nothing compared to the focus that was given to the weight loss journey that she'd been on, the exercise, the diet, and the proportion of it that was attributed to Ozempic use as well. And it just made me quite sad that here was a woman in her 70s now and still having photos of her body being placed side by side, and a huge focus of content around her physical figure, how she felt about that, in spite of the fact that she's there presumably in celebration of success. And all of this occurring, of course, in the context of what some people might describe as our toxic food environment, where we're exposed constantly to very cheap, highly calorific, really tasty treats everywhere. You'll see them in the supermarket aisles, row after row. And this all being given to us each day through advertisement, through media, against this other flip side of the coin, which is the strong drive always to have a certain type of physique that's considered desirable in the self, desirable in others, associated with health and fitness, associated with attractiveness, and so on. So, I don't think this is specific to binge eating disorder, but we have to think about all the eating disorders occurring in this sociocultural context, and how much of what goes on around us every day contributes to that. And I think also subclinically, even though we focus in our work on those who've reached the category of disorder, so much of this leads to subclinical everyday difficulty, worry, anxiety, stress around body image, around diet, around self-esteem related to food, diet, and appearance. But if I could turn now maybe to think about some of the underlying etiological theories behind binge eating disorder, and there are three mainly that I want to focus on. And I suppose, although we might describe them as competing with each other, I think the complexity of this disorder probably points to the fact that it's different for everybody, isn't it? What brings about their binge eating disorder? There may be different contributions from each of these etiological theories, or they may unhelpfully, synergistically, cooperate to bring somebody into having disordered eating. So the emotion affect regulation theory, this goes back to our initial diagnostic point at the start of the slides there about distress. Up to 95% of mood states, up to 95% of mood states prior to a binge eating episode are accounted for around things like stress, anxiety, anger, frustration, sadness, depression, and that these emotions are particularly overwhelming for people and lead them to carry out a binge. very often these emotions are related to interpersonal experiences, and these seem to be particularly relevant in binge eating disorder around anger, hurt, loneliness, disappointment, and so on. So individuals engaging in BD behaviors use these behaviors as a means of reducing the negative emotion, and therefore we think of it in terms of a maladaptive coping strategy. And this is very important, as we'll hear later, in terms of some of the psychological models of treatment that are in play and that have good evidence behind them. So the problem, as we take a step back, isn't really one of an interpersonal experience that goes wrongly for an individual. It's not even the emotional response that comes of that difficult interpersonal interaction, but it's the lack of more adaptive coping strategies that perhaps gets people into trouble with binge eating and leads to this recurrent practice. There's also a lot of thought going into the sort of neurobiological etiology of binge eating disorder as well. There are theories around the dysfunctional neural mechanisms in the brain's reward system, low dopaminergic state leading to more hedonic drives and reaching for more delectable, more dopaminergic type stimuli. There is functional MRI studies that demonstrate hypoactivity in the prefrontal networks and hyperactivity in the medial orbital frontal cortex. So the reward and emotion circuitry perhaps being more lit up, busier, more active perhaps than the thinking brain, the prefrontal cortex, where all the executive function is happening. And in a similar model, I suppose, that we see in addiction care as well, where there's a reduction in that executive function, that top-down control in binge eating disorder, and this is borne out in some functional MRI studies that have been carried out as well. And this takes us to the third etiological theory. The question is, well, is binge eating disorder simply another form of addiction? And theory here would say that predisposed individuals are biologically vulnerable to certain food types. They become addicted to these food types, and that these food types ought to be considered as toxic to them. Analogous to alcoholism or opioid addiction and so on, the feeling here would be that there's no real cure for this disorder, that somebody with this addiction always carries it throughout their life, and there can be no way of being completely rid or free of that addictive element. It can only ever be in remission. And I suppose it's worth thinking of some of the similarities here. There's certainly this description of loss of control over behavior that you might see in addiction, in terms of the onset, the frequency, intensity, the duration as well. You'd have urges and cravings, both in addiction and also in binge eating disorder as well. An increasing preeminence of binge eating over other aspects of life, to the neglect of other aspects of life as well, as you might catch in a dependence disorder too. And again, this idea that it continues in spite of clear, evident harm and an individual, having unsuccessful attempts to stop. So all of these features, you would say, would fall in similarity between binge eating disorder and some of the addiction and dependent disorders that we talk about. However, there are perhaps some important differences to highlight as well. There's no evidence, for example, of increasing the volumes or increased tolerance to certain amounts of food to achieve the same effect. It's more about the volumes of food eaten, or sorry, it's less about the volumes. It's more about there's no need for extra food to achieve the same effect. There's no evidence as well of physiological withdrawal. So somebody who might be withdrawing from alcohol or opioids, you wouldn't have a corollary of that within binge eating disorder. And typically with an addiction, you would find a narrowing of focus down to a single particular substance, whether that's within alcohol or drugs. Whereas it's more the varieties of food, the volumes of food that's of concern in binge eating, rather than any particular subset or type of food that becomes specifically addictive. Binges are distressing, carried out against a strong preference to avoid the behavior, which is not the case very often in alcohol work or addiction work, where, as you know, a lot of the work initially is around the ambivalence, the feeling that, yeah, there's bad parts of my addiction or my dependence, but also there's parts that I particularly like and I want to continue with. So there's a lot of work that arises in early stages of addiction recovery work before you get to that point, whereas people with binge eating disorder are much clearer in their sense of distress and dissatisfaction with the behaviors that they're carrying out. And in binge eating, there's a real vulnerability arising from the fear of the substance, from the fear of the food, I should say, which relates to the body image concern. You don't tend to see that vulnerability found in substance misuse. And I suppose I just wanted to spend a little time thinking about binge eating as an addiction, because many patients will go along to Overeaters Anonymous and get a great deal of support from that. However, this is built very much within the addiction model, and it's important to reflect on whether that's really the right appropriate kind of analogous approach to take. Step one, I'm not going to read through all the steps, but step one, we admit we were powerless over food, that our lives had become unmanageable. And the approach taken in this kind of addiction model recovery is very, very different from what you might see in CBT or other psychological therapies, where there is the prospect of full recovery without this concept of either being in relapse or in remission. So we might turn our attention now, if we can, to some of the treatments that are available for binge eating disorder, and some of the interventions that are out there as well. And I suppose it's worth reflecting that it's very variable, very much depends on the individual patient, what they've been through before in terms of treatment, what they're interested in doing themselves, whether that's talking therapies, medications, behavioral interventions, and what's been tried before with success or otherwise. But certainly psychoeducational interventions have a very strong efficacy in reducing binge eating and reducing eating impulsivity. And the goal here really is about reducing the stigma, reducing the shame associated with the condition, and reducing some of the isolation as well. The hope is to promote deeper understandings of the condition, of its associations as well, and to think about that circle I had a few slides ago. What predisposes the individual to certain relapses of binge? Is it the loneliness? Is it maybe comorbid alcoholism? Is it to do with emotional regulation? So thinking about what for an individual, perpetuates the problem, and then bringing in some skills to think about what things they could do maybe differently to reduce their risk, to reduce the frequency of the binging initially, and then to hopefully consider its eradication entirely. Things like food monitoring, really careful around restriction avoidance, being very careful about the dangers that come with a reduced calorie diet process, which done with the hope of weight loss can actually lead people into more difficulties because of the overwhelming binge urge that catches them in the end. The advantage of this intervention is it doesn't particularly require specialist intervention, specialist training around eating disorders. It can be delivered by individuals, or can be delivered to individuals, or can be delivered in groups as well. It's less effective in the research literature in managing maybe some of the associated comorbidities, such as anxiety, depression, as you might expect, and some body dissatisfaction issues tend not to be fully resolved as well. Higher dropout rates with this intervention associated with higher baseline pathology. But really, if we're to think about the most validated and the most effective treatment for binge eating disorders, it would be psychotherapeutic interventions. And perhaps the best studied of these would be cognitive behavioral therapy, which focuses on that aetiological model we talked about around emotions, around self-esteem, emotions, body image, and takes a very flexible and a very adaptive and individual approach to seeking out what for the individual is the driving thought or thoughts behind their binge eating practice, and looking using a CBT model to see what can be done to undo that and to weaken it and to build their coping strategies along different lines. So remission rates are really high, 50 to 60%. And I think that's really worth emphasizing, that eating disorders do have a reputation of being quite difficult sometimes to treat, can be intractable, can require lots of input and take a long time for meaningful recovery. Now, that's not always the case at all, and it's not the experience that we'd have in our work very often. But I did want to push back on some of that thinking, particularly when it comes to binge eating disorder, where the experience is that high rates of success, particularly around some of the psychotherapeutic interventions, lead to really, really positive results. Again, individual or group CBT can show similar results in terms of efficacy, and there's good evidence as well for self-help CBT or guided self-help as well, for those who may not be able to access support in other ways. Other therapies, DBT, dialectical behavior therapy, again showing similar efficacy to CBT with binge reduction. which has a much stronger focus, as you might imagine, on emotional regulation, coping strategies around stress tolerance as well. And then interpersonal therapy, if an individual's binge eating may relate very closely to their difficulties interpersonally, their disappointment, their loneliness, their isolation, then interpersonal therapy can be a really good mechanism to address that as well. So what we see with binge eating disorder is really a symptom of an underlying psychological process that responds very nicely with the right types of psychotherapeutic intervention. There are behavioral interventions as well worth focusing on too. Dietitian support crucial across all eating disorders, but thinking about the nutritional needs, the meal planning, the snack planning, you know, people develop all kinds of unusual ideas about what their diet should or shouldn't look like, from what they maybe read online, or maybe from their background, their growing up, their experience of food. And so we shouldn't take anything for granted or make assumptions about where people are at in terms of their nutritional understanding or their knowledge, and bringing that piece in as well is really important. I think some of the earlier literature you see on binge eating disorder from about 9 or 10 years ago would have focused on the secondary gain of weight loss, the idea that as well as reducing binge eating disorder symptoms, individuals were also securing some amount of weight loss with them, and that was seen as positive. Laterally, there's much more caution, as you might imagine, around that as being any kind of goal associated with binge eating disorder, because it is this drive to lose weight and to change the body image that so often gets people into difficulty in the first place. So very conscious that this isn't necessarily, the purpose of the type of treatment that we're undertaking. Physical activity, development of interests and skills, that sense of unstructured time, loneliness, isolation, taking an occupational therapy model as well, looking at ways that people can develop coping strategies that don't rely on binge eating as much, are have some evidence as well. Now, these are unlikely to be as effective as standalone treatments, the research would suggest, but certainly along with other interventions, as we mentioned, they can have a useful role and bring some considerable benefit to patients too. I take just a moment to think about some of the pharmacotherapeutic options, and just a quick slide about pharmacotherapy in general for eating disorders. There's a fairly limited role for medications. Societies for Biological Psychiatry suggested anorexia nervosa, a limited recommendation for olanzapine alone. Bulimia nervosa suggested recommendation for fluoxetine and topiramate. Binge eating disorder has relatively more available to us in terms of psychopharmacotherapeutics than the other disorders. And there is a recommendation for lisdexamfetamine and for topiramate, and a limited recommendation around some of the SSRIs and tamoxifen. So in thinking about the pharmacological management of binge eating disorder, the goal is really to think about what treatments might relieve the symptoms and any comorbid psychiatric disorders, referring back to that initial slide where we have 50% of people with up to 3 psychiatric comorbid disorders as well. So looking for opportunities to address both the binge eating and anything else that may be going along, and also considering the role of any anti-obesity medications if necessary, and keeping an eye out on physical health too, to make sure pharmacology in those domains has been considered fully as well. So looking at lisdexamfetamine, this is a stimulant medication that you may be aware of through ADHD particularly, a pro-stimulant which stimulates the release of dopamine, norepinephrine, and serotonin as well. And based on the outcome of 4 randomized controlled trials with 1,055 participants, you would see between 40 and 50% remission rate, which was significantly higher than placebo groups of 14 to 20%. So again, really good evidence there actually of the efficacy of lisdexamfetamine in managing binge eating disorder. Also helpful in relapse prevention as well, with 3% who continue on lisdexamfetamine not relapsing, compared to 32% who took placebo. Recommendation of dosing between 50 and 70 milligrams, and there's some side effects there listed as well, including loss of appetite, some nausea, irritability, sleep problems. Loss of appetite not necessarily being a side effect, perhaps something that might assist somebody with this condition. Of course, as with any controlled drug, there is a potential for abuse and diversion. This is a stimulant medication, So that needs to be thought about and considered. But there's nothing in the research literature that I've come across to suggest that this is an active problem in the binge eating disorder community, that there have been issues of significance in relation to misuse of lisdexamfetamine. And then thinking as well about topiramate as another option, topiramate being anticonvulsant, modulating ion channels and GABA and glutamate receptors. Again, reduction in BED symptoms, 58% versus 29% in placebo, and an association in reduced body weight as well. And a recommendation starting at 25, gradually building up to a maximum dose of 60. There's some limited evidence of increased suicidal ideation at higher doses, and it may reduce the efficacy of hormonal contraceptive pills as well. So for that reason, very often lisdexamfetamine is considered the first medication that people would go towards rather than topiramate. Now, I should say that these medications don't formally have a license within Ireland for the treatment of binge eating disorder. Again, you know, perhaps this being a relatively new disorder, the research isn't there, or it's not, we've not moved along far enough to get these into a position where they're approved. And in the States, the FDA has approved lisdexamfetamine for binge eating disorder, but as I say, we don't have that approval yet in Ireland, so it will be off license. Okay, so just thinking now in terms of primary care, and I suppose taking a moment to think about some screening approaches that could be undertaken, reflecting on the treatment gap, and then having a look at a primary care approach to treating binge eating disorder. So it's estimated that only 38% of people with BED ever receive a specific diagnosis, and very few people, only 3.2% of those in an online survey with meeting the diagnostic criteria, ended up with a diagnosis from a healthcare provider. So as with many mental health disorders and many eating disorders, a huge gap exists between those with the condition and those actually in active treatment for the condition. And there can be many reasons for this, and I suppose we've touched on a couple of them already. There's perhaps a lack of patient awareness, a lack of practitioner awareness as well, a lack of information available, and there's stigma, as with all eating disorders, and a great deal of shame, particularly around binge eating disorder. As we've described, lack of screening, and also this perception of it being perhaps a less serious eating disorder, perhaps relating more to a lack of discipline than anything else. So you can see that self-stigma there, making it even more difficult for people with this very serious condition with huge amounts of complexity actually coming forward and getting the treatment that they need. But this isn't unusual in eating disorder circles at all. And there's a study, a meta-analysis undertaken showing that internationally, the time for those who do go into treatment, the time taken from onset of eating disorder to treatment is 2.5 years for anorexia nervosa, 4.4 for bulimia nervosa, and up to 6 years for binge eating disorder. So it's just worth stopping and reflecting on the, you know, the duration of suffering and physical and psychological challenge that go with such a delay in diagnosis, and really what more could we do to kind of try to get these people identified early and into treatment so that they don't have the cycle and the huge impact that that has on them in their day-to-day lives. So as I say, advantages of early detection: far less psychological burden, less physical burden, and perhaps also a less complicated course of illness and treatment as well, for it being less less established as a disease. There's not much in the research about pre-treatment predictors informing us which patients have more favorable outcomes. But we do know that those who experience a rapid response, say up to 70%, around 70% of reduction in binge eating over the first 4 weeks, that's associated with positive sustained remissions over the longer term. So that's something that's worth looking out for. So there's a couple of screening tools that are worth using, and I've mentioned this one. There's two that I wanted to mention, which are not specific to binge eating disorder, and I think these have been developed to catch any kind of eating disorder at all. So they're very kind of overarching. Two positive answers in the affirmative here would be significant and would prompt further questioning, further diagnostic questioning to consider an eating disorder. I won't read it, it's there in front of you, so you can have a look through there. But those SCOFF questionnaires, some people don't begin with the first one. It can be quite a provocative one to be starting with. There might be other ones, you might do it in a different order. So the sensitivity for this particular screening tool is 86% with a specificity of 83%. And there's another disorder, another screening tool developed for primary care, which has a sensitivity of 100%, specificity of 71. And again, we're looking for two abnormal responses. The first question, are you satisfied with your eating pattern? If that's a no, that would be of concern. And the rest, if there's an answer yes, if it's answered in the affirmative, that would be of significance. So looking for 2 out of the 5 there to prompt further discussion and further exploration. And I always think the advantage of these screening tools is that, you know, they're a way to overcome some of these barriers, some of these stigmas, and they can lend themselves, or they can sort of open the gates to further discussions and a bit more development that might, you know, and it's difficult sometimes for practitioners as well to venture into discussions of weight and eating habits too, but the screening tools can be a useful way to overcome that, to bridge that gap. There is a specific binge eating disorder screener 7, it's called, which has 7 questions very specific to binge eating disorder with 100% sensitivity, only 38% specificity. But I suppose I'd be more inclined to think about using one of these 2 tools because they can capture more than one eating disorder and therefore will probably be more useful. So I found this diagram from a Canadian journal for primary care physicians, which I thought was really helpful in terms of how to go about managing binge eating disorder in a primary care setting. You know, beginning with a screening for it and then following through the algorithm there, working down to guided self-help, looking for a response. If there's no or a suboptimal response, then looking through to pharmacotherapy or individual evidence-based individual therapy. So it's quite a handy algorithm, as I say, to think about ways you might manage binge eating disorder in primary care setting. And thinking about guided self-help, these resources would come recommended, I suppose, particularly the first one there, the one with the image, Overcoming Binge Eating Disorder, very well established now as a CBT-based model of intervention that somebody could do by themselves to see if that might help reduce their difficulties around binge eating. So just before we conclude, I wonder if I might take a couple of minutes to talk a little bit about the eating disorder program here in St. Patrick's and some of the work we're doing on developing the binge eating stream of our work. So we have an 11-bedded inpatient ward, Clara Ward, where we accept patients with all kinds of eating disorder issues, anorexia nervosa, bulimia nervosa, and occasionally binge eating disorder as well. We have a 5-day-a-week daycare program, which is a mixture of remote model and on-site model as well. And then when that's concluded, patients would often go across to our aftercare program, which runs every 2 weeks and keeps people connected with the program and provides a bit of sort of sustainable support post recovery. We have outpatient clinics as well, and there's certain psychological supports available through our service here around compassion-focused therapy for eating disorders, or Mantra, which is a Maudsley intervention for psychological therapies for anorexia nervosa. We're very fortunate in that we have a large multidisciplinary team deriving experience from a variety of disciplines, as you might imagine. And we take referrals, of course, from the GPs, from CMHT and other teams within the service. But I suppose what worries me sometimes is that our referrals for binge eating disorder are comparatively rare. And as I say, is in spite of the fact that we have, it's a much more prevalent condition than any of the others. At the moment, we do have a daycare binge eating disorder stream, and this was developed by our nursing team last year. It's a fairly new initiative. Looking, I suppose it arose really from the feeling that the daycare program really wasn't meeting the service user needs within the binge eating disorder category, that we're finding that there was a bit of detachment and they're not really engaging, not really feeling the material was necessarily relevant. And I think in response to that, we developed a binge eating disorder stream, which has had some good success so far. We've been really pleased with how it's been developing. However, there is a gap in the service we think that we want to address because it's not clear, you know, the suitability of inpatient care, patients with binge eating don't tend to severely restrict to the point of having a kind of a physical concerns that you might get in anorexia nervosa per se. There's not the binge purge pattern as well. So a home care model, a model based from an intensive intervention based from home might be more suitable to meeting those patients' needs and make it easier for them to access the service without having to come into hospital. So what we're hoping to develop in the next couple of months, hopefully starting next year, is a process that leads into the binge eating disorder stream in our daycare unit. That's a more intensive, maybe 3-week binge eating disorder program that tries to get in and look at some of these complexities that arise from binge eating, confirm the diagnosis, think about any comorbidity that might be there, look to the physical needs of the patients as well, look at that risk that occurs in binge eating disorder to a multidisciplinary team input from the dietitian and social worker, OT, psychology as needed as well. So just a sort of a more holistic and more in-depth approach to binge eating disorder, and maybe giving it more of the preeminence it needs and more of the input that's probably required, particularly where there's complexity, and then an opportunity within that to think about the use of psychopharmacology if required as well. And we're hoping to build that, as I say, in the coming months, to see how that goes. So I suppose that brings us to the end of the discussion on binge eating disorder today. And listen, thank you all very much. I really appreciate your attention this evening to go through what I think is a really important and often overlooked topic. So yes, thanks once again, and I'd be very happy to open for any questions or any comments or any feedback at all. Thanks very much.
Thanks so much, Gary. Your timing is impeccable again. Just enough time left for questions. There's just so much in there, really, really interesting. I wasn't actually aware that binge eating disorder is the most common eating disorder. I think there's probably a misconception that it might be anorexia because you hear of that probably the most. So that's really interesting in itself.
I think that's exactly it, isn't it? It may be overshadowed perhaps by some of these other disorders which are less frequent, less prevalent, are serious disorders, of course, in their own right.
Yeah, of course.
But perhaps there's a concern that binge eating doesn't get maybe the airtime it needs.
Yeah, the same recognition. It's great to be able to so I suppose focus specifically on it today. If anyone does have any questions, you'll see the Q&A function there at the bottom of your screens. There's a little question mark in the box to make it easier to spot as well. We did actually have a question that was emailed into us earlier as well, so I'll just pull that up. Yeah, so would you have any recommendations for treatment or best practice in a case where someone has suffered from restrictive anorexia for many years with numerous hospitalizations and inpatient care, but where weight is now restored and binge eating has developed? Enhanced CBT is due to commence soon.
Thank you. Yeah, I suppose this goes back to that point made earlier that people do drift from one diagnosis to another over the course of their illness, and that sounds like it's been particularly tough thinking of the duration of illness there. And I suppose it would be the same treatment that we went through a few slides ago in terms of thinking about the CBT approach, maybe aligned with other interventions around the psychoeducation piece, perhaps some OT dietitian input as well. The only caution would be, I suppose, if somebody has a history of anorexia, that some of the medications options may lead to some weight loss, which might be complicated. Now, that's not to say that they're exactly contraindicated, and if they're helpful in managing the symptoms, then there's an argument for them. But I suppose that would just be a caution around that we would have to be careful of, and maybe keeping an eye on the reaction of an individual to certain medications. But I think to answer the question directly, it would be the same model of treatment and care, and a conversation really with the treatment providers in terms of what's been tried before and what from the array of therapeutic interventions is most likely to be acceptable to the individual, and what can they best work with, even if that's on a trial and error basis, you know.
Yeah, I think the person had mentioned, sorry, I'm just trying to pull up the question, but they had mentioned that they speak quite openly about the eating disorder as well, and they're aware of distorted thinking and behavior, but open to all advice, so that's great.
I think that's great. If somebody, the difficulty with binge eating, as we referred to in the earlier slides, is this idea of alexithymia, or an inability to speak about your emotions, really. Having an openness and an ability to connect with what's going on for you emotionally, I think goes great distances in getting this kind of support and the kind of intervention that will make a difference, you know?
Yeah, absolutely. And I know we were speaking about it earlier before we came on the webinar, but the documentary that was on RT last night about, now obviously it was specifically anorexia, but they talk about getting the supports, the early intervention as well. So it's very interesting to see it all lined up. Another question is just in terms of Ozempic. So obviously over the last kind of year or so, the use of Ozempic, particularly I suppose in Hollywood or in that kind of celeb circle, has become really popularized. And I'm just wondering in terms of kind of clinical practice or how it's translating to clinical practice.
Certainly in the treatment of binge eating disorder, there's trials not yet underway. I think they're looking into doing some research around the use of Ozempic in binge eating disorder. It hasn't, those trials haven't been conducted or haven't been completed yet. So they'd be very interesting to see, you know. It's just, I suppose, the hesitation in my voice is around the weight loss thing that I was talking about earlier, isn't it? That we really try hard to kind of work on people being comfortable, whatever weight they happen to be, and for this ability to not go down the Hollywood route. Really,
of course.
You know, and to radically accept that we can be healthy at all different kinds of weights, and that, you know, that people, because there's such a drive towards weight loss that leads to binge eating disorder that we have to be so careful to catch ourselves out with that. But equally, there, you know, it's really worth looking at all interventions, all options, and Ozempic being among them, to see what that might be able to do for our patients in terms of delivering from some of the difficulties they have, you know.
Yeah, absolutely. I think that picture is all that you brought up earlier with Kathy Bates just really reinforces this kind of, I suppose, drive to be a certain weight or to congratulate people for losing weight. And it's just, it can be
in the
so
context
harmful.
of being there to celebrate incredible achievements in her life, which have nothing to do with her figure. And
I know.
the only thing, I mean, that's what people are reading, and it kind of, they're reading it because they're so concerned about weight themselves, you know, and it's just this cycle that we have as a society that we're trapped in around image and figure and what that means. And
it's just a vicious cycle, isn't it?
It's absolutely, it really is,
I'll just see if we have any other questions coming in there. I have the curse of having two screens. The things keep bouncing around, so I'm trying to see. So I can't see anything in the Q&A there. If anybody does have any follow-up questions, they can just email us through to communications@stpatricks.ie and we can try and answer those if we can. There's also more information about the eating disorder service at St. Patrick's Mental Health Services, specifically on our website, which is stpatricks.ie, so you can see more detail as well, the specific day programs and the kind of an overview of the eating disorder service as well. So I think, there's no more questions. I think that's it from us, Gary.
That's great.
Perfect.
Well,
thanks so much.
Thanks very much, everyone, for joining. And
thanks everyone. Take care. Have a nice evening.
Good night.
Bye.
Bye-bye now. Bye-bye.